Okay, welcome everyone to our OpenSim webinar. My name is Jennifer Hicks. I'm the OpenSim R&D Manager and also the Associate Director of the National Center for Simulation and Rehab Research. I'll be serving as the moderator for the webinar today. I'm pleased to welcome today's presenter, Kate Saul, who is joining us from North Carolina State University. She'll be discussing her methods and results for interpreting upper limb dynamic simulations in the context of clinical variability. Next slide. Before we get started, some reminders about the goals of the webinar series for the OpenSim project. The OpenSim is a freely available software application for visualizing musculoskeletal structures and simulating the movements of humans and animals. So the first goal of our webinar series is to showcase cutting-edge research that's being performed with these tools in OpenSim. OpenSim is also a growing and geographically diverse community of users. So the second goal of the webinar series is to provide a platform for the OpenSim community to collaborate and communicate. Next slide. Before we get started, I have a few reminders about the format of today's webinar. So we will address your questions at the end of the presentation using the Q&A panel. We do want lots of questions, so start writing those down as you watch Kate's webinar, and then we'll address those at the end of the talk. If you need any additional technical help, you can also consult the guide on our website. Next slide. So now I'd like to tell you a little bit more about our speaker for today. Dr. Saul is an Associate Professor of Mechanical and Aerospace Engineering at the North Carolina State University in Raleigh, North Carolina. She received her undergrad degree in engineering from Brown University and her master's and doctoral degrees in mechanical engineering here at Stanford. She was previously at Wake Forest School of Medicine, and she's been at NCAU since 2013. Her research draws from mechanical engineering analyses of dynamics and control to answer clinically relevant questions about dysfunctional upper limb movement, with her goal being to improve treatment outcomes for patients with neuromusculoskeletal disorders. So you'll hear about some of this today. I'm excited for Kate's talk, which is a great mix of modeling and clinical applications. So with that, I'll let you take it away, Kate. And don't forget to unmute your microphone as well.
So hopefully you all can hear me now. Jen, can you hear me? Are you guys able to hear me?
I can hear you.
Okay, great. Well, then I'll go ahead and get started. And I wanted to thank Jen again and the rest of the OpenSim team for inviting me to speak today at the webinar. We'll be talking, as she mentioned, about our work in computational simulation, interpreting upper limb dynamic simulations in the context of clinical variability. As many of you may know, clinical movement dysfunction and rehab of the upper limb can be quite challenging to clinicians and to researchers due to patient variability in presentation or their response to treatment, or to our incomplete understandings of the mechanisms that underlie injury or deformity. So what I'd like to do today is to share some examples of our group's approach in our simulations within OpenSim, share a little bit about the details about how we perform these simulations, and talk about how we choose approaches that represent the variability that we see in clinical problems, as well as talk about how we select outcomes from our simulations that look very similar to clinical assessments so that we can translate our results better to the clinic. And before I get started, I would like to acknowledge the contributions of my former graduate student, Dustin Kraut, who should have a PhD after his name now, whose work forms the bulk of the talk that I'll be sharing with you today. So briefly, as an overview, our group is interested in clinical conditions, and recently we've been focused on brachial plexus palsy and rotator cuff injury in older adults, as well as interventions that are used to restore function to these patients. This motivates all of the work that we do, and in general, we try to incorporate both experimental or clinical measures from imaging or strength assessments or functional assessments into our computational simulations so that they better represent the patients that we care about, as well as allow us to incorporate those details into a simulation so that when we look at our results, they are more relevant to the clinical population that we care about. We also attempt to use computational simulations to generate hypotheses and design better experimental studies. And taken together, we return this to the clinic and are really striving to have translational work. Pretty much all of our simulations take sort of an overlying workflow that I'll share with you here, and then we'll look at the specific workflow for the simulations of each study that I'll talk to you about today. In general, we start from a generic musculoskeletal model of the upper limb that we've developed in our group in concert with Wendy Murray, and represent changes that we observe clinically to muscles or to the joints, to the muscle paths, or to their force generating capacity into the model. And then we use that within the framework of OpenSim to create dynamic simulations of movement. Often we have to create many of these simulations to capture some of the variability that we're interested in. And so I'll talk a little bit about the MATLAB batch processing approach that we use in order to facilitate those simulations. And in general, we try to choose clinically relevant outcomes, either movements, strength assessments, metabolic cost, and other features that are really relevant to the clinicians that we're interested in working with to translate our results more directly. Today, I'll be focusing on our work in brachial plexus injury. The brachial plexus is a network of nerves that supplies the muscles of the upper limb and can frequently be injured during traumatic injuries, which may place those nerves in traction and either tear them mid-substance or pull them directly out of the spinal cord. And the result is that muscles, especially those crossing the shoulder, often those crossing the elbow as well, can be paralyzed, and this leads to reduced use of the upper limb. This can be difficult to treat clinically for a variety of reasons. Frequently, there are concomitant injuries due to the traumatic nature of the injury. There can be multiple concurrent treatments that happen simultaneously, making it difficult to tease out the effect of any individual treatment. There's often variability in the treatment success, and there can be post-injury muscle changes that aren't well understood. And so it makes it very difficult to evaluate the biomechanical consequences of these injuries and the roles of individual muscles as targets for treatment in the context of clinical evaluations or even experimental work alone. So we use a computational approach so that we can isolate the effects of individual muscles or the effects of individual treatments in order to have a better understanding of how they're contributing to function in these patients. However, patient variability is really important to consider in our biomechanical analyses. We need to think about how other injuries to the surrounding muscle or the patient's response to treatment, which may vary from individual to individual, may affect our biomechanical conclusions. As a brief review for those of you who are not upper limb people, some of the important muscles that we'll be talking about today are the deltoid, which is perhaps one of the more famous shoulder muscles and very superficial, shown here. Some of the other muscles are the latissimus dorsi and the pectoralis major, which tend to want to bring the arm in towards the body. Some muscles of the elbow also do cross the shoulder. So the triceps, for example, crosses behind the shoulder. You can extend the shoulder sort of towards your back, while the biceps crosses in front and can move your shoulder in flexion or anteriorly. Some other important muscles are those of the rotator cuff. We'll be talking about the infraspinatus, the supraspinatus, subscapularis, and teres minor today. All of these muscles work to situate the humerus in the glenoid fossa of the shoulder. It keeps the shoulder pulled together and can also move the shoulder in internal rotation, which would be actuated by subscapularis, or external rotation by infraspinatus and teres minor. So these are important muscles that we'll be talking about today to just kind of keep that snapshot in your mind, and we'll revisit it later. The model that we use in all of our simulations is based on a model that we've recently released on simcp.org in both OpenSim and Sim implementations. This model, the mobile arms upper limb model, is named for the labs of myself and Wendy Murray, our close collaborator, and is a dynamic model that can be used for the simulations that I'll be describing today. This model is built on a foundation of an earlier kinematic model which is often referred to as the whole bar model, which is my previous name. That model captures the motion of the glenohumeral joints, the elbow, the forearm, and the wrist, and represents the force generating capacity of the muscles crossing these joints. In the new dynamic model, we make some augmentations and improvements in order to optimize it for dynamic simulation. We've included new descriptions of the inertial parameters of the segments of the upper limb. We've represented passive restraints and damping at the joints of the upper limb, which implicitly represent the action of ligaments and other structures that restrict the range of motion of these joints, which is important for forward dynamic simulations especially. We have improved descriptions of the peak muscle forces for the muscle actuators in the model based on measurements that we've made in living adult male subjects using both medical imaging to assess their muscle volumes as well as match strength profiles for those individuals and use that to appropriately scale the shoulder, elbow, and wrist for match strength across all the joints. And finally, the original kinematic model was implemented in SIM. We've updated the muscle pads to improve their performance and the speed of simulation for use in OpenSim, and to ensure that the moment arms that are calculated in OpenSim match those that we intended in the original SIM implementation. So this model will form the foundation for all the simulations that I'll describe to you today, but I'll describe how we've altered this model to represent our specific patient group that we're interested in for brachial plexus analysis. So what I'd like to share with you are three sort of case studies of how we've incorporated different types of patient variability into our model and use that to assess the outcomes for different kinds of interventions or assess underlying mechanisms of injury in these patients. In the first, I'd like to focus on how we incorporate variable response of a patient to a surgical intervention by comparing nerve transfers to the axillary and suprascapular nerves. So a nerve transfer is one approach that is often used to restore function to paralyzed muscles following a brachial plexus injury. Motor fascicles from a donor nerve that is not impaired are used to restore innervation to an impaired muscle, and the extent to which these are successful depends on a number of factors. One is the choice of donor nerve or target muscles that are restored, because often you can't restore all of the muscles that are paralyzed. It depends on the technique that the surgeon uses, including whether a graft is needed to reoppose the ends of the donor and the target nerve that's being repaired. And it also depends on the patient himself and how well he responds to this nerve transfer, especially how much force is restored after the nerve transfer is performed. This in particular is quite variable and not well understood, and so it's an important feature that we included in this particular simulation that I'll share with you. Restoring shoulder stability is a really important feature or a priority for clinical restoration of function following a C5, C6 nerve injury, which impairs the muscles crossing the shoulder. There are two sort of main targets. One is the axillary nerve, which restores the muscles that are shown there in blue, the deltoid and the teres minor. Transfer to the suprascapular nerve would restore the supraspinatus and infraspinatus, those muscles of the rotator cuff. And then transfer to both nerves would restore all of these muscles. So clinically, the conventional wisdom is that restoring to both nerves is preferable when that's possible, but due to the extent of traumatic injury, sometimes that's not possible, and a choice can be made between either the axillary nerve or the suprascapular nerve as a target. So our question is, which strategy is best based on the contributions of the muscles that they target? So to do this, and throughout this presentation, I'll have these little workflows that show us, that highlight the tools that we're using within OpenSim, and the things that we're doing specifically in OpenSim are highlighted in yellow. So hopefully that will help orient you as we go through. So we start with the generic musculoskeletal model that I've described to you, and we performed a computed muscle control simulation of the movement that is showing there in the video, in which the shoulder is required to be stable, abducted, or away from the body, while the hand is brought towards the body, though one is feeding themselves or doing a self-care task. Computed muscle control identifies the coordination or the activations of the muscles in the model that are required in order to track the movement that we've asked it to do. So it's trying to figure out what is the best way to coordinate those muscles with the least metabolic cost in order to produce that movement. And that was described by Phelan and Anderson and is a tool within the OpenSim framework. You can restrict the amount that the muscles are activated during the computed muscle control algorithm. So we do that by restricting the paralyzed muscles that we know to be paralyzed to 0%. So they are not allowed to be activated. They can only produce passive forces. We, in all of our simulations, represent a concomitant transfer to the musculocutaneous nerve, which restores muscles that flex the elbow. This is very frequently performed in concert with the transfers to the shoulder muscle nerves. And those have been restored to 20%, which is based on reports of elbow flexion strength after this kind of a transfer compared to the contralateral elbow. But the real question is about the shoulder muscles. So what we did is that we varied the activation limit for the muscles that are being restored from the axillary or the suprascapular transfer and vary it from 0 to 100% in 5% increments until we find, well, we do it for all of those cases and we look for where the restoration is sufficient in order to perform the movement that I'm showing you in this video. And we repeated that for 4 clinical scenarios, an unimpaired scenario with a healthy arm, and then the 3 transfer scenarios where it's to the axillary alone, the suprascapular alone, or both of them together. Because this is so many simulations, we used a MATLAB batch processing approach where we can, through MATLAB, call the tools within OpenSim and run these simulations one right after another so that we don't have to do that manually within the user interface and we can run them as one big group. So then we look at those simulations and we're looking for clinically relevant outcomes. So the first one is whether after the transfer the arm can perform the motion. So really, is it strong enough to do it when we've simulated it? And so we looked at the CMC tracking error to see whether it was able to perform it or not. If the tracking error is large, that means that the joint angles are much different than what we told it to do, and it was not able to perform the simulation. We also look at how sensitive the surgery is to force recovery. So we look at what % force was needed in order to perform the CMC accurately. Then we looked at which muscles are contributing. So we looked at the joint moments produced by each muscle crossing the shoulder during the motion. And we looked at what effort is needed. And to do that, we looked at the metabolic cost function, which is used within the computed muscle control algorithm. In this case, it depends on the volume of a muscle, and that's activation squared, and that's summed over all the muscles in the model across the whole movement. So we calculated that using the states that are produced from the simulation. Okay, so the first question is, can it perform? So the simulation on the top is one that's performing it accurately. You can see that the shoulder stays stable while the elbow flexes. In contrast, at the bottom, we have one where that is not happening, and let's see if I can get it to go again. The shoulder is drifting towards the body as the elbow flexes, and so that would be unsuccessful. So we looked for what restoration level was needed in order to keep the shoulder stable. And that's what we're looking at here. So we're looking at the % of force recovery that's required for each of these types of transfers. And what we see is that 15% force recovery was required in the combined transfer in order to perform that simulation accurately. So that means that the combined transfer of these 3 options is the least sensitive to how much recovery the patient experiences, and they'll be able to do this one functional task with a relatively low level of recovery. In contrast, axillary and suprascapular require more recovery, with the axillary requiring only 25% force recovery to perform the task, while the suprascapular transfer required up to 40%. So it would be the most sensitive to how much recovery the patient experiences. If we look at the joint moments, we can see why this is so. So here what I'm showing is the shoulder elevation moment as a percent of the net moment required to keep the shoulder stable in an abducted posture. For each of the 4 nerve transfer scenarios, what you can see is that deltoid, which is the tall white bar, is producing almost all of the shoulder elevation moment in the unimpaired, axillary, and combined cases. However, in the suprascapular case, it's not able to do that because it isn't restored. So infraspinatus and subscapularis and supraspinatus, which are rotator cuff muscles, are now required to help elevate the shoulder in a way that they aren't in the other scenarios. So they're able to do it, but it comes at a cost. And that cost is that the rotator cuff muscles have other jobs. And their other jobs are to rotate the shoulder. So now we're looking at the shoulder rotation moment rather than abduction. And what we can see is that the subscapularis is a big internal rotator, and the infraspinatus is a big external rotator. So those muscles are now...
Sorry to interrupt you, but we seem to have lost your slides. Is it still there?
Are they there now?
Yes.
Okay. Sorry, I don't know what happened. I could see them. All right, well, we'll continue. Did you see the previous slide? Hopefully, yes.
Maybe you have it in presenter view and we're clicking on the other side of
No, I just was using my mouse, and so it somehow...
Okay,
anyway.
Well, we can see it now, and I don't think we missed anything.
Okay, great. So as I was saying, the deltoid, important rotator cuff muscles have to take over when deltoid is not available, and the problem is that they're rotator cuff muscles, so they internally, darn it, there it goes, internally and externally rotate the shoulder. So they're co-contracting in order to stabilize the shoulder in rotation while at the same time abducting the shoulder. That high level of co-contraction has a metabolic consequence. So here we're looking at the movement effort relative to the unimpaired movement effort for the 3 transfer scenarios. And suprascapular, which is shown in red, has a much higher movement effort relative to axillary and combined, both of which do have a cost that's about twice of the unimpaired case. So this consequence may mean that clinically these patients may get more tired and be unable to perform tasks at a higher level for a longer period of time. And again, this movement effort comes from that cost function from the computed muscle control, which we calculated from the muscle states. Okay, so in that first example, we were looking at variable response, comparing the axillary and the suprascapular nerve transfer, but we were assuming that basically all of the other muscles were available to compensate for the muscles that were impaired. But that's not always the case, and so to explore that in more detail, we'll look at how variable presentation may affect one's conclusions by comparing, delving deeper into the axillary nerve transfer and looking at the strategies that are used to perform that transfer. So as I mentioned before, the axillary nerve targets the deltoid and the teres minor. The deltoid has 3 independently activated compartments, the posterior, middle, and anterior deltoid compartments. And because of the anatomy of the axillary nerve, you can actually choose to restore only parts of these 4 muscle compartments. It has a branching architecture, and so if you chose to restore only the anterior branch of this nerve in a transfer, then you'd restore anterior and middle deltoid. And you might want to do this because, as we saw, deltoid is really important for abducting the shoulder, and so you'd have more motor fascicles available to those muscle compartments, and you may be able to increase the percent force recovery, which we saw was important in the last study. In contrast, you could choose to transfer more proximally and restore all 4 of the muscle compartments. That would mean you've had more muscles restored, but it may be at the cost of having a less overall force recovery for the individual compartments because you have the same number of donor fascicles that are available to those muscles. So the question really becomes, do we need posterior deltoid and teres minor, and if so, when? So we did this by looking, again, at outcomes that we think are clinically relevant. One is their contribution to the maximum moment during simulated isometric joint moment assessments. So these are basically an isometric strength task. But we also need to know what they're doing during submaximal movements and what muscles are compensating for them when they're absent. So we look also at joint moments and activations during simulated submaximal movements. So again, our flow here is to take the generic model and to make only two scenarios, one in which all muscles are available, so they've all been restored, and one in which only the anterior compartment has been restored. And so we're looking at a case where posterior deltoid and varus minor are paralyzed. Then we use two assessments. We use the plotter tool in OpenSim to calculate the isometric joint moment in a given posture shown there, and also looked at used computed muscle control to simulate some submaximal movement tasks, and looked at the joint moments and activations of the muscles under both scenarios to identify which muscles are compensating when posterior deltoid in particular is paralyzed. So first we'll look at the isometric joint moment, and we looked at three different joint moment directions: abduction, extension, and external rotation. And again, using the plotter, we looked at the maximum joint moment and looked at which muscles were contributing. And so we can see very quickly that blue, which is the anterior branch muscles, are extremely large contributors to abduction. And so they're really important, and you can understand why they would be good targets for restoration. In contrast, the red muscles, the posterior branch muscles, don't contribute very much in any direction. So whatever the other gray muscles are really doing quite a bit of, producing quite a bit of moment in abduction, extension, and external rotation. So just from this, you might say, well, we should restore the anterior branch only. But if we look to the submaximal task, then we will understand better what those gray muscles are and how they are called upon to produce movement if the posterior branch is paralyzed. So we looked at three submaximal movements: abduction, shoulder extension, and external rotation. This is often performed in the clinic as well. And we looked at the shoulder moments that are produced when posterior deltoid is present and when it is absent. So this is just a snapshot of one example of shoulder extension moment or abduction and extension motions. We can see the muscles that are also producing abduction and extension during these movements. When posterior deltoid is there, when posterior deltoid is paralyzed, then these three muscles, suprascapular, triceps, and lat for the abduction, and middle deltoid, triceps, and latissimus dorsi for an extension motion, have to increase their joint moment. If we look at the activations, we get an even clearer picture of which ones are compensating. So I'm showing here the mean and maximum activation during that movement for those same muscles for the motions shown by the diagram. And what we can see is, in particular, supraspinatus and triceps really have to turn up their activation, which is already quite high, in order to compensate for posterior deltoid absence. So this is important to know, because if those muscles are not available to compensate, then it may be really important to have posterior deltoid available, and you may want to restore it. So when would that happen? If we think about the clinical condition, often this type of injury to the axillary nerve would happen in concert with the supraspinatus tear, if, for example, a shoulder dislocation is the cause of the injury to the axillary nerve. So then it may be really important to restore posterior deltoid. Similarly, if there's a radial nerve palsy or something else that's injuring the triceps and causing it to not be available to compensate, then again, you would probably want to restore the posterior branch of the axillary nerve. However, if those muscles are available to compensate, then restoring anterior and middle deltoid alone is probably the priority, given how much they contribute to shoulder abduction. Okay, so in the first two examples, we focused on adult brachial plexus injury, where we feel like we understand reasonably well the kind of injury that's happening to the muscle. But that's often not the case, and it's especially not the case when we're thinking about brachial plexus injury that happens at birth, which is something that can happen when the head and the shoulder are pulled apart from one another during the birth process. At that time, there are changes to the muscle that are not very well understood, and that can influence the deformity that occurs in these patients. So in this last study, we'll take a quick look at that. Patient patients that experience this perinatal birth palsy frequently have persistent deformity of the shoulder, which can, in 1/3 of cases, persist even when nerve function is recovered in these developing children. The kinds of deformity that we see are both postural and osseous. On the top is an example of an osseous deformity. So this is a cross-section through the shoulder. On the left is a normal shoulder with the humeral head situated right against the glenoid fossa of the normally shaped scapula. In the right side, we have a deformed shoulder where the humeral head is sort of misshapen and it is moved posteriorly relative to the scapula, so it's dislocating out the posterior side. And you can see the overall shape of the scapula is altered and tilted backwards, which is called glenoid retroversion. In addition, there are postural deformities, which include a limited range of motion where the shoulder is restricted and rotated inward and unable to have full external range of motion. And there are also abduction contractures of this joint as well. So these are really serious consequences that affect the development of these individuals and their function throughout their lifetime. And it's not very well understood what changes are causing these observed deformities. One long-standing clinical hypothesis is that there's an imbalance in strength between the unimpaired internal rotators and the paralyzed external rotators. So the internal rotators would be pulling the arm into that internal rotation postural deformity that we see down here. Another more recently suggested mechanism would be that there's an impaired growth longitudinally of the muscle. So basically the muscle can't add sarcomeres and series as the bones and the body continue to grow. And so that if this
Kate, sorry to interrupt. We lost the, oh, it's back, yep.
Yep. When that happens, then you would imagine there would be very high passive forces pulling on the bones that can have similar results. So if we knew which one of these was at play, or perhaps both of them were at play, then we would have a better sense of which types of mechanisms should be targeted by clinicians in order to restore the shoulder to its healthy development. So our question is which mechanism and which muscles can even cause the deformities that are seen clinically given their biomechanical action. Certainly there are some of them that are arranged in a way that would make it even possible for them to provide the kinds of forces that would be consistent with the injuries or the deformities that we see. So in this case, we have to alter the model in an iterative way. So now our MATLAB batch processing catches the model iteration as well. We start with the generic model, and we, for every single muscle crossing the shoulder one at a time, either changed it so it represented a strength imbalance. So we activated that muscle by 30% while leaving all of the other muscles unactivated. And a muscle acting by this mechanism would need to be unparalyzed following the injury. We also represented an impaired growth by reducing the optimal fiber length of the muscle actuator by 30%. Again, one muscle at a time. And muscles that would be acting by this would have to be paralyzed following the brachial plexus injury. We then did a forward simulation under each of these conditions for a relaxed arm hang, where the arm is just hanging by the side. And for that simulation, then we would calculate what the joint force was acting at the shoulder. We would think that a force that is consistent with the kind of injuries that we see would have to be posteriorly directed, which would be consistent with that posterior retroversion. And then also plotted the passive joint moment and used that to identify the range of motion for abduction and for internal-external rotation, and use that to evaluate the postural deformity. So we have an osseous deformity measure and a postural deformity measure. Okay, so what we're looking at here are the results from a muscle imbalance sensitivity analysis, where we're looking at the contributions of each muscle to the glenohumeral joint force. And what we're looking at is essentially the change in magnitude and direction from the non-impaired case. So those muscles that are shown in orange are creating much larger compressive forces that are directed more posteriorly. And what we see are that the subscapularis, interspinatus, biceps, and lat are muscles that would be able to direct the glenoid force to be more posterior and more compressive. And muscle imbalance, again, would require that these muscles be non-impaired. But what we know is that most of these muscles are, in fact, typically are paralyzed following brachial plexus palsy, and so it's unlikely they would be acting by this muscle imbalance mechanism. Some of them do recover function after some period of recovery, although the deformities do not go away. If we consider the impaired longitudinal growth, then we see interspinatus, subscapularis, and biceps long head again are ones that could contribute to this posteriorly directed force. And in fact, they are paralyzed. So they are good candidates for muscles that could be acting by the impaired longitudinal growth mechanism and contributing to the osseous deformity. We also know that in a murine model of brachial plexus palsy, some of these muscles have exhibited impaired longitudinal growth. So that's some other evidence that this may be at play. If we look at the range of motion, we were only able to find that impaired growth could influence restricting a range of motion, and strength and balance alone could not. Again, we see that anterior deltoid, subscapularis, and triceps now are playing a role in restricting the range of motion of the shoulder, and some evidence that this might be happening clinically is that a surgical release of subscapularis has increased shoulder range of motion in children with brachial plexus palsy. So that's some circumstantial evidence that this kind of mechanism might be at play here. So since we're running out of time here, I'd like to go ahead and conclude that our simulation approaches have elucidated by mechanical principles in both progression of deformity and treatment options for brachial plexus palsy. Consideration of biomechanics and roles of individual muscles allows us to consider more targeted treatment, as well as experimental design for further study of brachial plexus progression. So for example, in the previous study, we identified some candidate muscles and mechanisms by which they may be causing deformity. So those would be really good candidates to examine more closely, for example, in an animal model, which is some of the other work, complementary work that we've been doing in our lab as well. But I would like to stress that incorporation of variability parameters or the population is really important to clinical interpretation of simulation results. And in making this more accessible to clinicians who they themselves see a variety of presentations in response to treatments. And so we really want to acknowledge that in our simulations and make sure that that is conveyed as we consider our results. And so with that in mind, I just had a few final thoughts in terms of the simulations themselves. It's really important to represent the major features of the patient population in a model. There's been a lot of recent discussion of subject-specific modeling and individualized modeling, and one criticism is often that it's very difficult to measure all of the parameters that one could include in a musculoskeletal model and thereby capture all of the features of an individual patient or subject. But our argument is that including especially those features that are most prominent or most different from one population to another, as we did in this case in terms of their activation, or if there are known strength differences from one population to another, those are the most critical elements to include in a given model. We really emphasize choosing outcomes that are parallel to clinical assessment to the types of things that are done in the clinic. While we can obtain a lot more information from simulations, and those are also very important, certainly the roles of individual muscles that we presented here are something that are not typically able to be assessed in the clinic. Relating those back to things that are very clinical not only allows it to translate to the clinicians, but allows us as modelers to further validate our model performance to relate, for example, the magnitudes of the restricted range of motion to what's been reported clinically, to relate passive forces in the muscle to what's been measured surgically. The more that we can continue to sort of spot check and validate our models, that also makes all of our modeling stronger. It's important to consider common presentations when you're presenting the results and acknowledge that muscles that you're for example, suggesting our important contributors may or may not be available. And being aware of those can help you create better simulations that better represent the clinical scenario. And finally, use simulations to improve your experiments. We have the opportunity through simulation to perform, as we did with the batch processing, many simulations in a relatively short amount of time that would be impossible or impractical to do in experiments, but we can limit the focus and the scope of our experiments. We can develop more concrete hypotheses as to which muscles, for example, might be acting to produce deformity, as we did in our third study, and use that to perform more focused and ethical experiments. So with that, I'd like to acknowledge our collaborators and funding sources, and again, especially acknowledge the work of Dustin Crouch, my former graduate student, and I'd like to take any questions.
All right, thanks, Kate, for a great talk. That was a lot of really interesting applications and modeling, and everything was very clear, so thank you. Now we can go ahead and get started with the Q&A session. So as I mentioned earlier, we'll take all of your questions in text form. So to ask a question, go to your WebEx controls and find the Q&A box. Then type in your question and make sure you select to ask all panelists. Again, find the Q&A box, type in your question, and then choose ask all panelists. So I will let people start typing their questions in. And in the meantime, I have a question for you, Kate. It's an upper extremity modeling question. So I was wondering, kind of first in general, how do muscle strengths scale in the upper extremity for different sized individuals? And then, you know, is it pretty uniform for individuals of different size or total muscle volume? And then do any of the, how does that change in pathology?
Yeah, that's a good question. So some of our work using medical imaging in a variety of age groups has indicated that within a given age group, the scaling from, say, shoulder to elbow to wrist, as well as individual muscles, is extremely consistent across individuals within that group. So there's very low variability in a healthy population. There are changes with age. In particular, the shoulder becomes has less volume and less strength relative to the other joints with age, and this can be seen as early as, you know, middle age. Those changes are subtle at the beginning, but by adults, the shoulder is weaker or the same compared to the elbow instead of stronger than the elbow as it is in young adults. So again, that's something that's important to consider if you're looking at, for example, an older adult group versus a young adult group. There are differousces, excuse me, of course, for individual injury populations. So we did do some other work in rotator cuff injury, and we know that the rotator cuff muscles atrophy with their injury, and the relative volume of those muscles relative to one another can change from patient to patient. So, you know, when we're considering those kinds of questions, we absolutely, if we have the data, try to represent the force generating capacity of those muscles separately, individual to individual, because it does influence the coordination and the joint reactive forces at the shoulder. So it is something to consider, especially if you're working with an injured population, to represent those changes.
Great, thanks. I guess one quick follow-up to that. So for your dynamic model that you recently published and released, what are the muscle strengths based on?
Sure, they're based on work that we did in healthy young adult men. So they basically represent a 50th percentile male with their matched muscle volume and strength profile measured in the same subjects from the shoulder, elbow, and wrist.
Okay, cool. Thank you.
Sure.
Now we have a question from Carolyn Salvi. She says, great talk. As a follow-up question, are the assumptions made with respect to the models you use entirely based on the populations you're studying? are there computational assumptions to consider as well?
That's a good question. So there are kind of a couple levels of the computational simulations, right? So there's the model itself, and that, you know, as we discussed, we do alter depending on the population to the extent it's relevant to the question that we're asking. Then there's the simulation part, which is using the model in a computed muscle control or forward dynamic simulation or the plotter. Some of that is subject specific in terms of if we're, as we did here, limiting the activations. If we have EMG, we might use that to limit the activations within the computed muscle control algorithm. We might use kinematics that we've measured for specific patients, or restrict the range of motion of the model to represent their individual subject range of motion, especially if pain is an issue, because we wouldn't want to simulate postures that are painful to specific patients. In terms of the actual like simulation parameters, in terms of I don't know, there are parameters within computed muscle control, for example, with regard to tolerance and you know, other technical parameters. Those we mostly don't alter, other than we may, depending on the task that we're simulating, if it's an extremely long task or an extremely long simulation, we may increase the number of calculations that are permitted in the tool in order to allow it to complete. But mostly we don't change the technical simulation parameters based on any clinical reason. But the muscle parameters and the model parameters, we would.
Okay, thanks. I have another question that's a little more general question, and I'll try to make it specific. So your results, each of the studies, they have important clinical applications that, you know, would be valuable to a surgeon who's deciding, you know, which procedure to perform for an individual patient. Have you done much work already in trying to translate your findings to a clinical setting, or even do any more clinical type studies where this is incorporated into the planning or the surgical planning process?
Yeah. So
what have you done, and kind of what's the reception so far?
Yeah. So we've done this, you know, to greater or lesser extent in a couple of ways. Most of this work is published in clinical journals, and so we're directly translating it to the clinicians in that way. Some of this work has been presented as an exhibit at the American Academy of Orthopedic Surgeons to describe how we can use simulation in order to do some treatment planning and illustrate principles of, you know, that was more of a rotator type of application, and that was pretty well received by clinicians. We had a little demo, so we reached out to clinicians in that way. In terms of translating it to more clinical work, we've also done some work with patients and experimental work, both for rotator cuff and for brachial plexus work in adults. So that's been more on the research side of working with clinicians to identify good candidate patients and doing assessments within the lab to both verify some of our predictions in our simulations and also to relate more concretely clinical measures that can be used in the clinic, like isometric strength assessments, to performance of more complex tasks. So we're kind of attacking it from a couple different ways.
Okay, that's great. Thanks. It's really important, but I know it's challenging as well. Yeah. Okay, if anyone else has questions, please go ahead and type those in. I guess there was a technical question. Someone lost part of the presentation due to their internet connectivity. And so I was wondering if we'll make it available, recording of the webinar available afterwards. And yes, we will. Anyone tuned in will get a link to where you can watch a recording of the webinar. So we will take care of that. It looks like that may be all the questions for today. So I think we can go ahead and wrap up.
Well, thank you. Before you go on to your other slides, I just want to say thank you and also invite people, if they have additional questions, they're welcome to contact me directly.
Yeah, and after the webinar, in addition to a link to the recording, we'll also try to send some relevant links to any CPK projects, so the one with the model, or relevant papers as well, so that anyone interested can learn more about Kate's work. Okay, so wrapping up, if you can advance to the next slide for me. So we did that, the questions. Thanks everyone for the questions. I do want to acknowledge our funding sources. So OpenSim and this webinar series are supported by several grants from the NIH, including the NIH grant that funds our National Center for Simulation and Rehab Research. We're also supported by DARPA and the Warrior Web Project. Next slide. Again, thank you, Kate, for a great talk. Thank you to all the audience members for a great discussion. You can find more information about the OpenSim project, upcoming events, and other resources from the OpenSim community on our website. There's also a link there from our website to sign up for our mailing list so you can get emails about upcoming events and new resources. We also will ask that you complete the short survey that's going to appear in the pop-up window at the conclusion of the webinar. This will help us improve the webinars and also choose upcoming topics. So thank you again to Kate. Thank you all for participating. We hope you'll continue to stay involved with OpenSim. Thanks, everyone.
Thank you.